Hello, everybody. Welcome to Tough to Treat. I'm Susan Clinton, your co-host, along with my co-host, Erica Mello. Hi, Erica.
Hi, Susan. How are you?
I
Happy
am
New
well,
Year.
thank you. I think Erica's fresh off of a vacation in sunny,
Yes,
warm Florida,
sunny
and I'm
Florida.
sitting in Sault Ste. Marie, Michigan, with about 10 inches of snow on the ground and negative temperatures. So
Mm.
as they say, it's all in what you're looking for. So we got the snowshoes out. We're hoping to get out on the
Uh,
trails this week.
oh, so jealous. Love it.
So anyway, here we are, podcast number 113. And before we launch into it, we wanted to remind everybody that our membership for our premium podcast club is up and ready to go. We have recorded our first interview with Jessica Schwartz. It's going to be a part 1 and a part 2, and it is fantastic.
It was amazing. I learned so much. It was crazy.
Worth the price of admission.
Yes.
More than worth the price of admission. So many helpful things
Yep.
for people treating people with persistent post-concussion symptoms. I've learned
That's
a
a
new
lot of
word.
people.
I
Yes.
learned a new word, right?
Yep.
So yes, and that there's and how many there are. So join us. You're not going to want to miss this special premium podcast. And our podcast club also, our Ask Us Anything is open in the membership site. If you're a member, come in and ask us anything. Later this month, Erica and I will go on and record our responses, and we'll have it live. We'll post it live. So if you want to join us, great. If you're in the club, if you want to listen to the recording later, that's fine too. So we're looking forward to those who have joined us. We're excited, and we're looking forward to more people coming in and bringing in their energy and excitement and enthusiasm and questions into the new year.
Yes.
So toughtotreat.supercast.com.
Yep.
toughtotreat.supercast.com. Join us.
Yeah, it's gonna be awesome. It's a great value, and the Ask Us Anything alone, Jess's interview is worth it alone. To be honest, It's amazing.
100%.
How many people have post-concussive syndromes? You don't need to have a concussion, quote unquote, to have post-concussive symptoms. Have you ever fallen and hit your head? Have you ever just fallen and not hit your head? That falls under that whole realm, right? And it was such a wealth of information, totally. And the Ask Us Anything is fantastic too. You and I love answering questions. So and I keep saying this, but it's so true, because over the vacation I was looking at podcasts, and this is like the only, I would say not the only, I mean, there's one out there that does something similar, but the clinical mentoring and the personalized attention that we give to our listeners is pretty much unprecedented in our field, I believe. So I think this is a great opportunity to get more of us. So we would really love to see you in the club, and it's toughtotreat.supercast.com. So on to the episode. Thanks, everybody.
Yes, thank you, everybody. Hi, everyone. Welcome to podcast number 113. I'm Susan Clinton, one of the hosts of Tough to Treat, along with my co-host, Erica Mello. And today we're going to be talking about a client that I had seen that actually presented to me postpartum, 2 years postpartum of her second child. And she was complaining of pubic symphysis pain on the right side. To make a long story short, she had a fairly normal pregnancy the second time, the first time as well. She had pain going into delivery for her second labor and delivery, and the pain didn't worsen. It didn't get better. It didn't really change between, the third trimester and her first, post trimester after having the baby. She did seek out physical therapy care, and she wore, a binder around her pelvis. She had lots of manipulations. She was taught how to, quote, put her pubic symphysis back in. She was told that one side was slipped up over the other. She had x-rays that didn't show a separation. That was, maybe a little minor one, but not anything big. But she still has this pretty significant pain, and it's mostly on the right side. It's in the center, but mostly kind of travels to the right side. And so some of the things that she complains about were things of pain worse with turning in bed, sit to stand, sitting and shifting, sitting and driving. And, of course, sexual activity is very uncomfortable.
Mhm.
Not because it hurts in her lady parts, it's that symphysis, that pubic symphysis pain
Mm.
is worse when she has her, when she's widely abducted.
Mhm.
And she said that, so I asked her, what it is that she's, what's working well for her right now. What has she discovered? This has been going on for 2 years. And she said that she's not able to run, but she can walk as long as she doesn't walk for long periods and she doesn't like power walk. So she can do Pilates as long as it's not asymmetrical. So if
Oh.
one leg goes up and the, kind of like
Yes.
what you would expect, running
Yeah.
is the same thing.
Yeah.
And that the same thing with yoga. She's okay with yoga, like doing certain things, but if it gets into too much asymmetries and twisting, it brings her symptoms on. So she has trouble with some of the, warrior poses and the different things like that. But the floor exercise and stuff, if she can control it, works fairly well for her. So, and this is, I asked her about carrying her kids. She said it's worse when she carries her young child. Definitely, she's had to shift him to the left hip. She'd prefer to carry him on the right, but she just can't do it. And she always forgets and then gets reminded suddenly.
Yeah.
Then she does have a little bit of mild stress urinary incontinence. She says, especially with the full bladder. And she's not real sure if it's because when she decides that she needs to go, she just can't go in a hurry. So, so we have a little bit of some urgency frequency, a little bit of, some incontinence associated with that. So kind of leads us down the road to like a little pelvic health information needs to be gained here too. So to make a long story short, she definitely filled out a fluid diary. There definitely was a lot of urgency frequency, which tells me that we have an over recruiting pelvic floor, and probably in response to pain and worry and stress and the other things, too. So because she had pain going into labor and delivery, pain coming out, very minor tearing, nothing that needed to required stitches or to be repaired. Everything healed well. So we started talking a little bit about fluid logs and down training for the pelvic floor a little bit so that we could kind of get that to stop over recruiting so much. But one of the the movement piece here sounded so important and critical to me that I almost felt like the urgency frequency may not have been the driver. Sometimes I know we talk in this podcast about visceral drivers. I kind of feel like that the bladder was a victim here, and it was intuition that brought me here. So we went through our battery of exams, but before we start with that, is there anything that you wanted to ask or know, Erica?
Yes, this was her. Was this her first child?
Second.
Oh, second child. Okay, and she didn't have anything after the first child?
Nope.
Okay, and what's the age difference between the two kids?
The age difference is 2 years.
Oh, 2 years. Okay.
So at the time I saw her, her older child was 4 and this one was 2.
Got
around
it.
that time frame.
And then you said sitting also bothers her, correct?
Yeah.
So it's like a lot of activity, or any sitting, sex, turning over in bed. Does she have any other prior movement history, any prior injuries?
I asked her about that because we certainly want to know that, and I certainly asked her about pain during other pregnancies and things like that as well. And she could not really remember anything. She said, I had, kind of maybe an ankle sprain or two, a knee sprain, shoulder sprain. She was kind of an active soccer player in her youth. But she didn't remark, she wasn't in any accidents or injuries, like no car accidents, no slips and falls, at all. Then, she just said, just really kind of just came on in my third, trimester. And of course, everybody said, don't worry, you'll feel better after you have your baby. And she didn't. And she did seek out physical therapy care, but it was unhelpful.
Yeah. Was she bigger, or like, what was the difference? Did she say the difference between the first and second?
Yeah, that's an interesting question. And, one that, she didn't have much of a change in her BMI. She's not a very small person. She's not a large person. She's just a female with kind of a curvy figure. And, so, nothing really different. She felt, fairly good. The pain was the only thing in the second pregnancy that she had.
Got
And
it.
of course, she's also, you have to remember, second pregnancy, you're not able to rest as much. You're not able to
Right.
slow down as much because you're chasing, at that point, she was chasing around a 2-year-old. So,
Two-year-old. Oh my gosh.
so there
Yes.
was, some sleep issues and,
Yeah.
because you're still caring for a child that may or may not be sleeping through the night, or you're trying to sleep train again. And,
Right.
just, and the busyness of having a 2-year-old and having pregnancy and,
Right.
just if that alone, the stress hormones can be a little bit higher. And there are some really good works out and research out that is looking at actually salivary cortisol and pelvic girdle pain in pregnancy.
Oh,
So
interesting.
yeah, so it may not be, so when we talk about the pelvic joints, that maybe they don't move as much, but they have tremendous sensitivity to nociception, or they're,
Mhm.
there's just a, they're during, especially around that pregnancy postpartum period, they seem
Mm.
to be, the system can be hypersensitive in that area. And it makes sense. There's a lot of agency around the pelvis and the abdomen during pregnancy. There's a lot of, there's a lot that's going on there. And although the joints don't move, as we know, like they thought they did, so much, it's barely perceptible. That doesn't mean that those joints can't become highly sensitized. And generally, they talk a lot about things being loose. And generally, for me, what I've seen is that things are really being held tight.
Mm-hmm.
It's triggering an over recruitment kind of
Mm-hmm.
activity. And the pelvic floor is certainly showing that up with
Yeah.
the urgency frequency. So kind of thinking along those lines, manipulation would help a little bit, but she said it would never stay. And they taught her how to do it. And it's just
Yeah.
like, she just, she says, I do it, but I don't know if it really helps. So
I'm assuming she's
sometimes
talking about that shotgun that we all talk about, abduct.
that
Yeah.
she said she
Yeah.
did the shotgun. She's done the, putting one hand on the knee and the other hand under the
Yeah.
knee,
Yeah.
and that, those types of things. And she just isn't finding really good relief. So I did ask her, I said, how do you get it to settle down?
Yeah.
And she said, if I lay down and I put my knees up on the couch, my like, so she's at 90 bend. And, she says, I can get things to kind of just calm down.
Hmm.
So that position feels good to her, which is interesting because sitting is not good for her, but the positioning
Yes.
is good, feels better because it unweights everything.
Yes.
And she
Yes.
just feels like that she can just,
It's a lovely
that
position.
everything just relaxes and settles down.
Yeah.
She says she doesn't usually have time to do that, but she tries when she does because it does help.
Mm.
Um, the car, obviously, with all the sitting activities, the car's the worst, pushing on the
Yeah. To the
gas
right side.
pedal and it's the right
Yes.
side, and
Yeah.
those things, and shifting around, reaching behind the seat, reaching over, to like make sure her kids aren't doing something crazy,
Mm-hmm.
all of the
Oh,
things that are going on.
yeah.
So so the movement things, and and I would probably say that Erica will agree with me on this, is that the thing that I was the most interested in was what did she look like on one leg. That
Mm.
was kind of in the back of my head, was like, we really need to see what this one-legged stuff looks like. Asymmetrical movements. She's unable to run. Walking, brisk walking or long stride walking bothers her. Turning in bed, so I'm kind of thinking load transfer,
Yeah. Yeah.
immediately, that there's something going on with load transfer here. What has gone, what is happening in the movement system? So we, do the normal thing. You stand and you just take a quick look at the posture, see if anything is just standing out, in symmetrical standing. Everything was kind of okay. That, maybe she was a little bit shifted to the right, which was interesting because
Mm-hmm.
she hurts on the right, but she was shifted to the right. So I had her do a bend over. That was fine. That didn't really bother her so much. Again, she's symmetrical in this
Mm-hmm. Yeah.
position.
Exactly.
And so then we went ahead and did a squat, just right down into a squat. And the
Mm-hmm.
interesting thing in the squat was watching her standing on, and a little bit more to the right. When she went into the squat, she really shifted all the way over to the left side,
Mm.
and and the left pelvis dropped down more than the right.
Mm.
And that's when I could see the change in her feet too. She kind of like,
Interesting.
allowed her foot to be pronated to one side on that right side. And so that was kind of an issue there.
So she offloaded, so she squatted and she offloaded.
Mm-hmm.
So she offloaded when she squatted, she went from right to left and did the whole center of mass shift to the left. Okay.
Yes.
That makes a bit more sense. Yeah.
Mm-hmm.
Yep.
Okay. And, totally not unexpected.
Yeah.
But it was really, you could just really see the shift happen. And, I asked her to come back up and try it again and see if she could stay even on both feet. And if she did that, she could go down, but only halfway.
Because of symptoms.
Interesting.
Mm-hmm.
And I asked her, I said, can you go any deeper? And she goes, no, I don't think I can. So I asked her, I said, how much does this bring on your symptoms? Well, some, but she just didn't feel like she could go down that much further. Remember, this has been going on for 2 years. So the movement system has really pulled her over. And it may have been just a total, like, I can't motorically figure out how to do this.
Exactly.
So kind of put that in your, on the sidebar and think about that a little bit there. And then, so we went to, doing one-legged stance, just stand on one leg. I started her on the left. And she was able to stand on one leg. She did shift quite a bit to the left side and no symptoms. And then I asked her to stand on the right. And this is where it was very, very, very interesting. She shifted to the right, but her entire pelvis also rotated. So in other words, the left pelvis rotated back, the right pelvis rotated forward.
Right.
Essentially internal rotation of the hip.
Yeah, so her whole pelvis rotated to the left.
And a deduction of the hip.
So she had some I'm thinking compression as well, but exactly.
Yeah, compression.
Yeah, medial compression.
Almost taking somebody into like a FA, DDIR position, of the hip.
In standing.
Standing, with extension. And so that, and that did bring on symptoms.
Oh yeah, I would imagine it would.
And she was on the lateral border of her foot. And, it brought on symptoms. She was unable to hold it there.
Yep.
So coming in with my hands, I just got right onto the pelvis and said, let's see if we can work on controlling this a little bit. And she was unable to get her foot off the floor. When I kind of just kept her pelvis from rotating,
she couldn't get the left foot off the floor.
She could not get the left foot off the floor.
That's pretty. There you go.
Yeah.
She's poor. She can't control it. She can't control her pelvis.
Yeah, exactly. So, so we went to the wall and put her fingertips on, I just said, anything you need to do, put your hands on the wall, however you want to do it, hands, fingertips, whatever. She just put them right in front of her. I just had them up at shoulder level. And I said, let's try doing this, and it was interesting. She had trouble even lifting her right foot up because it kept her from like deviating on the left hip as much. So there was, some across the pelvis type of thing too. It wasn't just one-sided pelvic, which never is, the pelvic bones are a circle. And so there's going to be under and over recruiting on all ends of it. And then we went to the right, and again, same issue. She really allowed herself to twist into that internal rotation, a deduction, and then she could lift her left hip up. But she also noted that she was you could just see she was hiking that hip up too, trying to lift it. And the same thing when she went to the left, she would try to hike to lift her knee up rather than just allowing the knee flexion to happen, the hip flexion to happen.
Yeah. Was the compensation harder? Was it harder on the wall for her to do, or easier? Or was it the same?
The wall didn't really help much, but it did give her the feeling that, that she, what I'm saying? She could tell that sense
of center. Yeah.
You could tell that she was not able to, to do it because she couldn't compensate as much. She could compensate, but not as much.
Got it.
So it wasn't as, it wasn't as difficult when I took the pelvic rotation away because she still could do some of that.
Yeah, the wall's a game changer.
Yeah,
it does provide people
right. So I took her back off the wall and I put my hands on her thorax and I thought, let's just see, make sure I'm not missing anything. And the thorax was, that didn't stop any of the, holding the thorax didn't stop any of the twisting at the pelvis.
Got it.
Yeah.
Didn't make it
So
better,
yeah,
didn't make it worse,
nah.
didn't do
So
anything.
yeah, thorax was out. So I went down to the foot and thought,
Yep.
here we go. I'm just like, okay, I feel like I was chasing drivers at this point, but it was like important to kind of figure out what's happening here
Well, that's the
because
priority list.
yeah, and so we went down to the foot and just on the top bridge of her foot, the midfoot, all I wanted to do was just give a little input so that she wouldn't supinate so much.
Yep.
And, we had like something for her to kind of touch her fingertips to so she didn't fall over, just like being safe too. And had her try to lift her foot up and she still couldn't do it. So, the foot was important, but so is the pelvis.
Did the foot change the pelvic rotation at all?
Not really.
Okay.
She just wasn't able to. When we put the input into the foot, she didn't rotate the pelvis as much because she couldn't.
Yeah, so partially helped, but not fully.
Yeah.
Got it.
So then I wanted to look at a couple of things. I wanted to look at her in a lunge. So I gave her 2 chairs to hold on to because I knew she wasn't going to be able to. She already told me I can't do asymmetrical motions. And I said, let's just try this. And so I said, which one do you want to step out with first? So she chose the left, which I thought was interesting because it's the right one she has trouble standing on. And I said, just step forward first and just let your right knee bend. I'm looking at the ankle range of motion just to see what's happening there. Dorsiflexion.
The right leg was back.
Yeah.
The right leg was back on this. Yeah.
Yeah. And I didn't want her heel to come up. I said, just step forward as far as you can without your heel coming up and let your right knee bend. And let's see. And then we did it with the left as well. And her range of motion of her ankles looked pretty good. I could have pulled her into open chain and checked all that, but we were kind of on a little bit of a roll looking at the activities that were meaningful to her. It's like, why can't I stand on one leg? Why can't I walk? Why can't I run?
So her back leg, I'm just visualizing it. Her left leg was forward and then her back heel was down. So when she bent her knees, her heel had to stay on the ground.
Yeah.
Okay.
Because I was checking range of motion, like that closed chain range of motion of the ankle.
Yeah, got it.
So then we just did a lunge. I just wanted to see, what she could do. So I just lightly hold, hold if you have to. I don't want you to fall over, but let's just see what happens. And as she, stepped forward into the lunge, she really was off to the left side. And then when she stepped forward onto the right, she really had to hold on because she was going to the left. She stepped onto the right, but she was deviating to the left.
Same movement pattern.
So we've got a lot of over recruitment and some control issues there that have been there for a while. And and at this point, one of the things that I just felt like was like, this is definitely a control issue. But I also want to check the hip range of motion. She did have a good forward fold, but I just wanted to check it to see. So I got her on her back and we went through all of the motions, hip flexion and rotation and internal rotation, which bothered her more. Flexion, internal rotation bothered her more. Not a surprise there.
Yeah.
As it kind of fits, and she was also, when we were doing external rotation, she was getting some like symptoms around the side of her hip, which were kind of new.
Yeah.
I said, do you ever feel that before? And she goes, only when you're forcing it. And it's like, okay, so, not sure if the muscles were over recruiting and, that was kind of what was happening. Just kind of put that in there and just thought about it. And I said, let's get on your tummy and get on your hands and knees because we wanted to see what she looked like going into a sit back. I wanted to see if that same rotational pattern was going to show up there or if that motion would be different. And sure enough, as soon as she started to go past, as she got, halfway down, you could see that pelvis shifting. That left side was coming down and the right side wasn't. And there was that, the shift and she could force herself down, but it hurt. So, and she said that she says, I have trouble with child's pose. So we tried it with more external rotation at the hips, so widening the knees. And that seemed to make it a little bit better, but it was still there. So we have this tremendous rotational movement that's going on with her and a lack of control. And part of it is being driven because when she doesn't do that, it hurts. So now we've got
Yeah.
a sensitive system, some joints that have some hypersensitivity to them, whether you want to call
Yeah.
it central sensitization at this point or just, hypersensitivity, doesn't really matter. The name of the game is going to stay the same. How can I help her gain control without increasing her symptoms?
Right. And the pain generator probably was the pubic symphysis, or it is, but the driver it certainly wasn't at this point, right? I mean,
right. Or is that, it may have become sensitive, during her pregnancy,
yeah,
and the
yeah.
movement pattern that developed afterwards, has just kind of kept the train on the tracks
Right.
going.
Yes.
And,
Yes.
the only way she can really feel things really let go and feel better is to really unweight everything.
Yeah.
So, you were right in the beginning with compression as well as the rotational component that's going on there.
Yeah.
And it's just one of those things, she didn't know she was doing it. And, she said that, she wore binders. And I said, well, it's not, the binder isn't going to stop the rotation. It's going to, give you a little input, but it's not going to stop the rotational movements and stuff. So let's work on that. So her homework that she went home with was, it was the things that I asked her. I said, what do you want to work on first? What is going to give you the most, like, where are you like suffering the most? And so she said that, it was basically the walking.
Yeah.
So I said, let's work on some stuff then that's going to begin to help that get you some better control. So we started in standing with some foot exercises, just holding onto a countertop and just doing some pronation, supination, just trying to activate, lengthen toes.
Bilateral.
Yeah,
Yeah.
bilateral, just to like start to wake up the system on both sides, because she handled symmetrical movements pretty well,
Yes.
but she would still be stiff, so I
Yeah.
wanted to get her a little control in symmetrical movements before we moved to asymmetrical movements. And
Mm-hmm.
I just felt like she would get it would be much more comfortable for her.
Yes, yes. And one-legged standing for hip and pelvis, at least in my experience, is really hard for those
Right.
regions of the body, right? So it makes sense. You start symmetrical and in a nice standing, easy, go in the back door, so to speak, right?
Yeah,
And
exactly.
for the listeners, because that's, to go into right one-legged standing and working on balance for a patient like that immediately out of the box is, in my humble opinion, is something that I would not do, because and obviously you didn't do that, but just for the listeners, that's really hard to do, right? So sometimes you're like, oh, you're just standing and, pronating, supinating. Okay. But that actually works. That's the way into the system. That's what we need to understand. I think we can be a little aggressive sometimes, but that's the way into the system. Everybody's doing, anyway, I'm going on my
Nope,
soapbox,
it's
but
all
anyway,
right.
that's just the way in. You need to find the way in.
Yep. And so from there, we added just doing pelvic rotation with both feet on the ground. So
Oh,
she
how did you do
goes to
that?
she goes to left pelvic rotation pretty well. You have to kind of let your legs go, which is why I started with the feet and
Oh,
getting
yeah,
the
yeah.
feet opening. So then as you kind of like stand there and you go, that brings you into left rotation, of the pelvis.
So are you
But
bending and straightening your knees, or you're just,
I told her to keep her knees soft.
got it.
And so the
Okay.
interesting thing about that is that when you have both feet down on the ground and you do that left pelvic rotation, it's kind of almost the opposite of when you're on one-legged stance. So she had difficulty going to the left,
Interesting.
but with both feet down, but when, she could go to the right a little bit more. So we just played with it. I said,
Yeah.
we're not going to make any assumptions.
Right.
We're not going to make any,
Yeah.
we're not going to sit here and take this apart. Just go with how you feel. I want you to be able to feel comfortable doing this movement. And then I just turned on a little music so she could kind of get into a little rhythm with it. If you're thinking salsa movements, you're thinking correctly, but easy. Like one way she could go a little bit more, the other way not so much. And then as she kind of did it, the rules were, don't engage into the symptoms. Let's stay out of the symptoms and just move where you can move comfortably.
Yeah.
And and kind of get that going and add that into your day just a little bit, because she's on her feet during the day a lot and there's easy movements that she can do. And then we did the same thing on her knees. So we got on hands and knees and we just started working on just dropping the left pelvis and then dropping the right pelvis, left pelvis, right pelvis. And so she could, start to get kind of into a little bit of like, can I do this a little differently here? How does this feel? How does it work? So everything we did was in symmetry. And then I gave her doorknob squats because, you know, she was really going off to the left. And the rule of the doorknob squat is you're sitting back and you're not crouching. So it's a little different squat, but the doorknob helps with the symmetry, you know, the midline.
Yes.
You know, the door does. So, and she liked those. That became, she really, really, really liked that exercise, which was great. So I kind of said, well, then let's see how this works. Do these movements throughout the day. When you're really hurting, and I know you don't have time to lay down, do a doorknob squat to see if it helps.
I think that's a good little reset.
See if we can turn that into a reset exercise for her.
Yeah.
So she came back, still having the same problems, but able to do more of the movements in symmetry than she was. You know, that had started to really change. She liked it. It was easy to do. She felt like she was finally on the right track to doing some stuff. So then we immediately started transitioning to holding on to something and going into one-legged stance. So we grabbed the 2 chairs. And we started working on that because I wanted her to have some success, but I wanted her to have, you know, so she needed some control, some symmetrical control. So I wanted the arms down beside her. I could have done it with walking poles, and we'll get to that in just a minute. Or you could have put her hands back on the wall. Either way, I just chose that because we practiced the lunge stuff a little bit there. I thought it might be a good transition to go from where she could do one-legged stance to lunging, holding the chairs. Or just striding. So we just played around with that a little bit, and actually having the hands down beside her on the top of the chairs helped her control her pelvis a little bit better. You know, it just gave her a sense of, you know, plus she's motor learning all the time now, right? We've, you know, we've started jangling her motor system around, and so now her motor system is curious and doing things a little bit differently. And you know, so she was able to, you know, do the one-legged stance easier. And we just did the thing that, you know, where you have, you know, like Eric Franklin does with the headlights on the pelvic bones in front, don't get off the road. You know, so if you start to twist and the car's going off the road, you know, to help her kind of keep, you know, have a mental imagery going on, and only lift your knee up as high as you can. Don't let your whole pelvis come up.
How was her weight shifting? Like, did she really lose control when she really went into that loaded on the right, like lifting the opposite leg? So she was okay in a weight shift, and then the minute that right one-legged standing happened, I got it. Okay.
So we worked on the control of the weight shift.
Got it.
And then, you know, making sure that she wasn't going into hip hiking and other things, you know, this over recruitment business going on. And, you know, in order to help her with a little bit of control, I gave her some work with a little exhale as she did it, you know, so she could blow through pursed lips just a little bit as she went up as she, you know, lifted that left leg up, to give her a sense of just some control through the whole body, through the trunk, the pelvis. And, you know, same on the left. And as we did lunges, she added an exhale with the lunge, which just gave her a little sense of control so that she could start feeling that. So we moved from single leg stance, knee lift, single leg stance, stride, single leg stance, partial lunge, single leg stance, lunge, all holding on, and then various degrees of letting go. And then the progression from as we were doing that, we were also doing step up, step downs. You know, small ones. Like once she could get her knee up without hiking her hip, then I put the step in front of her. She could still hold on, but she had a target, you know, like, okay. And then we could start the weight shifting and the asymmetry for the stairs. And then as we got better with all of that, you know, over to the trampoline and doing some bouncing on each leg, and you know, eventually, you know, increasing her speed with walking. And then when she finally, the last time I saw her was about 8 months later, she was starting to run some, and she was very, very, very happy because she was doing some nice, good speed walks. She was feeling good most of the time. She would still have her moments like, I know if I twist and do something, you know, it kind of gets my attention, but for the most part, she was doing so much better with much more confidence. And, you know, we talked about that. I said, you know, it's going to take time for that sensitivity to go down. You know, and we talked about the importance of resting when she can, and, turning her, resetting the nervous system stress level. And,
Yeah.
not eating junky food, eating good processed food. We got her off the bladder triggers, the caffeine and the stuff that was making her urgency frequency worse. And, and that's was the other reason, to kind of date back when I first started working with her with the, with the feet and stuff. My goal was to like get that pelvic floor to stop over recruiting. And that's why the doorknob squats too, because
Yeah,
lengthening, and then the all fours lengthening. So I was
exactly.
going after some of those lengthening things as well as control, as an underlying current throughout. So
Right.
it
And
took
with,
a while. We had our ups and downs. She did,
yeah.
but for the most part, she really stuck with it. And busy, 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 busy person. So little bits here, little bits there.
Yeah, and for the listeners, I have two questions for the listeners. If
Mhm.
I mean, a lot of people can get really sensitive in those, like initially, she wasn't as sensitive, but even doing things backwards, like a backwards
Yeah.
walking or backwards stepping at the
Mhm.
beginning, if they're really, fear avoidant type
Yeah.
thing, those are always good.
Mhm.
Question, because I know we're probably going to get this question. You did not obviously do an internal exam and felt no need to, correct?
Right.
Yes. Okay.
Because
I didn't think that.
her symptoms began to abate.
Yes. Yes.
So if
I'm
her
guessing
symptoms
preempting
had
a
not
question.
abated, then I would have done that. But
Ah, okay.
it wasn't her priority.
No, no.
It was something that I felt like was, and I didn't feel like it was the driver. It could have been,
S-
but because the stuff we did started to get things to change, that's what we did. And when I was saying she had all the manual therapy before, she had a
Yeah.
lot of internal work before.
Oh, I can imagine. I can imagine. And even if,
So
because, yeah, I mean, they could have, when you see somebody who has that kind of a movement pattern in one-legged standing, medial compression, adduction, yeah, there's going to be overactivity, driving that, whether it's internal or external. All that release in the world won't help unless you figure out how to control the pattern. And
right.
I think that's the issue. And a lot of times when you can control the pattern, a lot of those quote unquote hypertonic muscles just let go without the need to do an internal
Mhm.
exam
Yep.
or outside hands-on. So yeah, because I know we're going to get those questions.
Yep. And that's great.
Yeah.
Ask away.
Yeah.
There's all different kinds of algorithms. I chose this one because I wanted her to return. She needed self-efficacy and how to care for herself. Number
Right.
one,
Yeah.
she just was tired of this. She just felt like she had been to everybody. She didn't understand what was going on. And she just really needed it. She was really wanting to just be able to go to the park and run with her kids. She really, really wanted that. And so that's where we started. And
Yeah.
if I had needed to add that piece in, I could have much easier than if I would have like shut it all down and started from the beginning like everybody else did.
That's
It's
exactly
like,
right. Like
and
everybody else
yeah.
did.
And the
Yep.
care she had after her pregnancy wasn't bad. It just didn't take her up into the movement system.
Yeah, and I think with somebody like her, you have to prioritize because she's had that all done. I mean, you're not going to do that again. And that's not she's still seeing you because you're
Yeah.
different. So, but I think it's important to note that a lot. You don't. What is the best use of your time? What's the priorities? What's important to her? That wasn't important. If it's not important to her in the first visit, it's not important to you in the first visit. If you need to, if you're like dying to know what's something, you can easily figure that out in subsequent visits. But in terms of like your own curiosity, but a lot of times when you restore control, there may be sneaky muscles that you need to sort of quote unquote release. I put that in air quotes, but a lot of times the balance just gets restored from a neurophysiological point of view, from as well. So I'm just, think everybody just really make use of the time and think about what's important for you in the assessment. What's your first thing out of the box? What's the first thing you're going to do? Anyway.
Yes,
That was
thank you.
awesome. That was
All right.
nice story, Susan. I like that one. That was good. They're all
Thanks.
good.
Yeah. And I forgot to add one other thing. The other
Yeah.
thing that I did with her was I had her work in front of a mirror because she really didn't have a sense of, what was happening. And I know the mirror is upside down and backwards visually, but I think there's also mirror neurons and things, when you see, sometimes she just needed the feedback for correction. And so she did practice some of the exercises and moves when we were getting to the asymmetrical stuff in front of a mirror.
Yeah, that's
and
great.
that helped too. She didn't have to stay there long, but I just added that in because
Yeah,
I thought it would give her some feedback, and she really liked that part of it because she could really see, because I see what I'm doing now. So, and that
yeah,
that helped her kind of clear
yeah.
that up too. All right.
Awesome.
Podcast
Thank you.
number 113. And everybody, we welcome you into our premium podcast club, uh, toughto treat.supercast.com. Join us for the new year and for our premium podcasts on interviews and Ask Us Anything. We look forward to working with you. Have a great day, everyone.
Bye.